Hi there, John. Welcome to the SOT podcast.
Hello, thank you for having me.
You're welcome. So you're an OT working in drug and alcohol services.
I
Um,
am, yes.
so how did you become interested in working within this field?
It's a little bit of a long story, which I will try to tell very succinctly. I guess it sort of starts, with my career journey into, I guess, health and social care. I was a support worker many years ago for adults with learning disabilities, and the same company had a role going in, working with young care leavers. And the sort of the project that I worked on, a lot of the young care leavers, these 15, 16-year-olds were using substances. So I was put on some training, and that sort of really ignited my interest for the subject. And if I'm honest, there was also that sort of element of it being a little bit taboo and like, oh, this is a little bit spicy. What's that all about? Sort of in my sort of naivety. And it kind of grew from there. The interest and sort of the roles really. So I got a job working as a substance use worker. Kind of again, sort of many years ago. So I sort of bounced around the country doing substance use work jobs for a couple of years before I decided to train as an occupational therapist. I was really lucky to go back into education. And then sort of lots of years of training, and then some more years of kind of working in generally mental health roles. And then this job came up, sort of a brand new role, developing the role of occupational therapy in a well-established substance use service in the south of Wales. And I thought, crikey, I can bring it all together. So I jumped all over that at the time.
And is that your current role at the moment?
It is, yes. So kind of we're getting to nearly to the 3 year mark. Kind of working in this role. So started entirely from cold. So they'd never had an OT before. They liked the idea of having it sort of added to the MDT, but if I'm honest, they weren't really sure. A lot of people weren't really sure what an OT did. And the health board OTs weren't really sure how a substance use service operated. So I sorry, I
Okay.
thought, can you, no, right, I'm just gonna, sorry, I should have quit Teams. Right, ask that question again. So
So
what
you're
was,
talking about your current role and the health services not quite knowing what substance abuse services did.
oh yeah, so kind of, yes, I started and, kind of, it was a real blank canvas. So it was also a sort of step up in grade, which if I'm honest, I wasn't really sort of, seeking out at the time. Um, so I thought, crikey, I just need to throw my all at this. So, um, it's a huge geographical area as well that I've got to cover. Sort of 5 counties. Essentially sort of the first OT or the only OT at the time doing this particular role in Wales. So it's not like I had any peers to kind of to pull on. So I kind of spent the first couple of months basically doing a literature review and meeting with anyone and everyone that I could, just in order to kind of basically, kind of launch into it with some sort of principle of evidence-based care rather than just going, oh, well, I reckon this. So, and kind of out of that, it sort of really paid dividends because actually I ended up discovering lots of other OTs working in substance use specific jobs and other sort of, kind of very much aligned jobs around the UK. And I've had people get in touch since that time, kind of from Australia, America, kind of lots of other sort of countries around the world. So it's very much, kind of something that we can do. And I think the thing that really excited me was the opportunity to kind of really develop this role and kind of not just the role, but the understanding within the profession as well. And that's something I've kind of found really energizing and really fulfilling alongside the sort of the clinical work with service users accessing treatment.
What sort of work are you doing with the clients? I mean, are you running a clinic? Do you visit people at home?
So kind of the service that I work in, we are community based. We facilitate a little bit of the inpatient stuff as well, and work alongside other parts of the system. So we do have colleagues not within our service, but who kind of cover the wards, and be that the psychiatric wards or the physical health wards. But me kind of my day to day, I do a lot of one-to-one work. So a lot of assessment. I also do a lot of intervention. I'm more of a fan of community-based work. I do use the clinic rooms, but I just think sometimes there's more to be gained by doing the work in the community and in people's homes because I've really tried to embrace the sort of holistic approach that we preach as OTs. So sometimes there's a lot to be gained from seeing someone in their own home environment. A lot of the time, I'm working with people who have both physical and mental health complexities. I mean, that is one of the criteria for people to come to our service, that they have severe and enduring mental health issues or physical, complex or unstable physical health issues. So we've also got this aging population of substance users as well. So there's lots, there's a whole lot for occupational therapy to bring. And so I do group work as well. I'm only currently running one group. I would love to run more. It's a wonderful community group, which is probably the highlight of my week, if I'm honest. It kind of grew out of recovery through activity. I think probably about a year or year and a half ago, maybe 2 years ago. What we found was that our service users, the complexities, the level of trauma, it was just far too much to expect people to come along for 8 or 10 sessions week after week. So it kind of grew into something a lot more flexible. Um, and I mean, I mean, I could talk for days about it. I absolutely love the group, and it's just this real pure using occupation to bring people together to improve their skills, improve their confidence, manage their anxiety, but also goes a real great way to challenging the internalized stigma that people have around themselves for using substances. Because we've got a lot of people who they've had a lot of years of society telling them that they're bad, they're wrong, they're weak, all these horrible things, and you see that reflected in the way people describe themselves. Um, so, I mean, I would say, I'm sort of predominantly model of human occupation based. I found that as a model really, really helpful, especially in terms of this conversation around what it is to be motivated and show motivation, especially in something as kind of complex as the phenomenon of addiction and substance use. I do work, so kind of we've got this wonderful group work, this sort of one-to-one work, which covers kind of all the wonderful things that OT can do. But I also do some work around sort of assessing people with alcohol-related brain damage as well, which is definitely an area to kind of keep an eye on for occupational therapy because it's only growing, it's only going to grow.
Thank you. And are you working as part of a big MDT?
I am, yes. Fortunately, so kind of it's got all the good traditional things an MDT has. So we have peer mentors. So we're just recruiting for another. So these are people who have the expertise by lived experience. So some of our peer mentors have been through treatment with our service. I think some people in the past have still been going through treatment whilst working for us, which kind of is a tricky line to draw, but can be an integral part of someone's recovery journey. We have a psychology team with psychologists, various trainers, people devoted purely to trauma counselling, as we see people with a lot of trauma history in our service. We've got all the medics, so consultant psychiatrists with lots of different special interests, other trainee doctors coming along. We have specialist support workers, so those who work kind of purely with kind of on the ground floor with our service users. We have alcohol related brain damage specific support workers, which I think they were the first lot in the country, kind of devoted to delivering the sort of the ARBD package of care from our clinics. Lots and lots of nurses, physical, mental harm reduction nurses, because we see a lot of people with potentially like wound care issues from self-neglect or complex physical health issues, or from kind of injecting behavior. So people may inject drugs, and over time, sometimes that can impact on circulation and other things. Um, and sometimes a lot of our people, they've had sort of bad experiences, or um, primary care or their GP services, or kind of whatever it may be, just doesn't offer the flexibility that they need in order to kind of attend to their wound care.
Mm,
So we have nurses developed to that, devoted to that, who also work really closely with midwives for parents using substances, or kind of pregnant women at risk or using substances, but also sexual health clinic nurses as well. So we do try to offer a great lot. I'm just trying to think. Obviously, it's always worth a shout out to our incredibly supportive admin staff. None of this stuff would work without them, as we are certainly finding at the moment. We're a bit short on the ground. Oh, who else have we got? Um, I think, yeah, kind of the nurses, kind of because we have so many, there's lots of discrete teams. So we have like a team of nurses that will liaise with local hospitals as well. Because if some of our service users go in, they're more likely to experience professional institutional stigma in not getting their medication in a timely way, or kind of the hospital staff being a little bit, or being outright reluctant or belligerent in
mm,
providing adequate pain care, or
mm,
kind of opiate substitute medications, um, or actually just sort of identifying that, oh, actually, is it something more cognitive rather than just someone being drunk when they present to A&E? So
mm,
we kind of try to tap into all parts of the system, really.
Thank you. And you mentioned the wound care. What other links would you say there are between substance abuse and physical and mental health?
I think it's sometimes it's sort of that chicken and egg sort of thing. Someone using substances, the nature of particular substances can lead to tolerance. So you need more in order to get the same effect, which some substances, if we say like alcohol, benzodiazepines, or opiates, opioids, can lead to physical dependency, which that sometimes, again, depending on the substance, can create these circumstances where it will have this really disruptive or destructive effect on people's, daily living, and their ability to do the things that they need to and want to, but also their relationships as well. I think I'm really interested in the sort of the concept of stigma, sort of far beyond this. We just need to kind of amend our words. There's far more to it, from like a systemic structural way, but also right down to an individual way, and the relationships that we have. So we've got people using substances who society tells them, again, they're bad, they're wrong, and that will only seek to marginalize people. So a lot of the time we're working with people who, they've got a lot of trauma. There's a whole backstory. And actually it can be really difficult, because we see people with kind of something referred to as tri-morbidity sometimes. So substance use, physical and or mental health issues, as well as homelessness or insecurity in accommodation as well. And if you think, crikey, all these things that an occupational therapist could already get their teeth into without the substance use involved.
Yeah, thank you. And with the stigma, how does that affect how individuals are then able to participate in their occupations?
I mean, I think there's lots of ways you can look at it. There's really clever ways of kind of delving into it. I mean, I think the kind of the part that I see myself as an OT, and kind of the role of occupation playing, is actually brings people together. When we ran the first group, kind of I say, kind of informed by recovery through activity, it just wasn't that structured. Um, we held a focus group. For the participants, we invited everyone to give their feedback. And we took feedback if people couldn't attend, so everyone had the opportunity to share their kind of perception and thoughts of the group. One of the really big things that stood out for me was this. The participants were like, "Oh, they're just like me. They're just, kind of other people, kind of, everyone was there, people using or had been using different substances. And it kind of showed that even within, a population, there's still levels of stigma. So if you think alcohol is legal, so people who might be drinking
Mm,
may look down upon people using heroin, for example, and people using heroin, smoking may look down on people injecting, and there's loads to it. But I think what I see and kind of what I've sort of promoted throughout the team is that the power of occupation in this really safe, non-judgmental environment that we put on um, appears to be going some way to sort of challenging that real internalized stigma that people feel. Because if you feel bad, if you feel you're wrong, it's going to be really distressing, and you're not going to seek help. Um, so this, kind of what we see is that, and kind of this is kind of backed up by kind of the evidence is that if people will only seek treatment when literally they have absolutely no resource, no coping
mm,
ability left. So that might be that sort of rock bottom that people talk about. And if you think, well, if only we could, if only there was a way we could kind of encourage people to seek treatment before everything just completely just deteriorates to a point where they don't want to live anymore. Um, and I think another sort of quick story on that front. It was kind of during my first year. It was one of the first chaps that I worked with, and he was he was very very sort of stable in his recovery to kind of use that language. No concerns about any kind of use alongside his kind of prescribed medications
mm,
for many many years, and he was working, and he had sort of other occupational roles based on his family. And he was really keen to kind of branch out into other um, community resources that weren't substance use based.
mm,
So kind of I supported him. We went and checked out this kind of one place, sort of in line with his interests. Um, and it was really enlightening because he sort of handled the social interaction really well. He's really confident, and he sort of signed himself up to do it. And then sort of a week or so later, we kind of checked back in because he decided not to go. And when I was exploring it kind of dawned on me like he basically what he was saying that even though people there had not um, said anything stigmatizing towards him, he, as a previous drug user and on medication, perceived that they would.
mm,
So there was just a real influence there. So this perception that you're going to be treated differently,
mm,
was really powerful, this chap, and actually sort of stopped him from engaging with that. And I thought, like, well, yes, you can't actually be your genuine self, kind of breaking into this. So how are you ever going to have a sense of belonging if you can't be who
mm,
you are because you're worried about, kind of the judgments of others? And it's not as easy to kind of say, well, shouldn't worry about what other people think because we all do.
yeah,
Um, and so kind of this stigma I see is still a real barrier to occupational participation outside of kind of the substance use activities, and it's a really good starting area.
yeah,
And we continue to sort of build bridges, but the service has had to go and speak to people, other professionals in different services. I mean, I'm thinking about a local sports centre who pulled some of our service users aside and kind of asked about their injecting status. And I'm like, what? What
mm,
what 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 relevance has this got? Kind of we've done all the referral, we've done all these things. So kind of some staff members went over there and kind of offered to do some training, which unfortunately wasn't taken up particularly well. But we still see it. People attribute all sorts of behaviours. Um, kind of other organisations that it's just banter, or kind of it's not giving people the due understanding of kind of actually it's taken a lot to get here today to,
yeah,
to kind of tolerate this. And I think that again that's where I see the detail as OT being key, because we will look at people's confidence and ability and skill in social interaction and communication and the interaction between others and the environment. and there's just loads to it, loads and loads, and I'd love I wish I had more time to kind of explore stigma in its different forms and occupational participation.
That's really interesting. And you've talked previously about the disease model of substance abuse. Do you think by seeing addiction as a sort of illness, that attitudes in society would help stigma?
I think it's served its purpose. For those unfamiliar sort of with the different models,
Mm,
I guess what we really started off with was the temperance or moral model of substance use. We're going back centuries now, sort of Victorian kind of attitudes to, well, you just don't have any self-control, do you? And it is a moral weakness in order. I mean, this was born out of sort of initial opium use and kind of the use of spirits. Kind of back many years ago, and sort of it became sort of more medicalized. So this sort of brain disease model, which in some ways it does sort of substitute one form of stigma for another, but then it's, I guess, sort of the issue. I mean, it's sort of the same with both of them really, but the brain disease model sort of can take away someone's agency. Like, oh, it's a disease, I'm helpless. Kind of, obviously you
mm,
can't speak for everyone. Um, but what it does, it still sort of seeks to other someone, so, oh, there's something wrong with you, kind of, we need to treat you. And we've had this medical model for God knows how many decades now, and all these clever drugs and things. It's not the whole story. Likewise, you've got self-medication theory, sort of social learning theory, or actually, it's kind of people with trauma. I mean, it's like no theory, no model ever covers it all. And I think that's where, kind of OT can kind of pull on all these different bits, sort of biopsychosocial, spiritual, kind of approach to kind of addiction because it's incredibly complicated, and everyone is using substances for a different reason, and no one's recovery journey looks the same.
mm. So going into recovery, how would you say that occupations and identity can change when people start going through recovery?
I think I'd sort of start by kind of just reminding any sort of OTs or kind of anyone, well, I guess anyone listening. I guess that a tenet of our professional thinking is that what we do, the occupations, can inform our identity, and they provide us with routine. They kind of there's this connection, this belief that occupational participation equals health and well-being. Kind of obviously very more complex than that. Um, and that's I think what I see is that you meet people kind of early on, say for example, just first entering treatment, and the way they describe themselves, all their occupations are based around maintaining their substance use, or they've been completely isolated from the previous occupations that made them them. So it might be loss of job, loss of family roles, and it all just sort of becomes whittled down a lot of the time into, well, I'm a substance user. I'm not going to repeat some of the horrible things that the way people describe themselves. Um, I mean that again, that's sort of indicative of internalized stigma and
Mm,
shame, and kind of sort of difficulties with self-esteem, and that's, well, it kind of makes sense if you don't have anything, you're not doing anything that makes you feel good, well, then you're going to sort of, that's going to be reflected in your self-identity. So, it's all about creating opportunities, actually understanding what that substance use means for that person, whether dependent or otherwise. And kind of actually the substance use treatment isn't the be all and end all, because service users, people accessing treatment, have needs, goals, aspirations, far beyond the moderation or cessation of substance use. If occupation can play a role in many ways, and actually, well, you can create a new identity through occupation throughout your recovery journey, um, throughout your detox, or kind of whatever it may be, because like I'm kind of drawn to kind of what are the reasons people relapse after they've been through treatment. Often boredom, often social isolation, unstructured time, negative social support, difficulty managing physical and mental health symptoms. And if you think, well, actually, that it's an uphill struggle sometimes, so actually occupation can be, well, no, wide-ranging in bringing people together, in actually creating these new identities and these new support networks, environments, bringing structure to people's lives. Because if you take away the thing, or seek to kind of work to take away the thing that was providing that person with, their routine, all this interaction, then what have you got? What else have you got? Kind of this is reflected in kind of the evidence as well, that it can be harmful to encourage people to stop using. Okay, yes, drugs and alcohol come with lots of problems, and some of them you can't, you cannot just stop, because you will put your life at risk for
Mm.
alcohol, for example. Um, so it kind of, you have to really consider what the substance use means for that person. That's something that's a real strength. So this is, the value of the occupational perspective of substance use can bring these new ideas, these new avenues for exploration, where someone may have just been around that kind of, the cycle of change, that recovery journey many times, and they're going to have low personal causation, aren't they? They're going to, everything they've tried before is going to tell them I'm no good at this. Well, actually, let's take a closer look at the skills. Let's take a closer look at the environment. Let's take a closer look at who you are and what makes you you. And it's kind of, sometimes it can be tricky acknowledging that. I think that's reflected in the literature, and just kind of a call out for the Rebecca Twinley's Dark Side of Occupation. It We need to be acknowledging this, and kind of by acknowledging this, it's not all harmful.
Mm.
um, some people's use of substances does enable them to participate in occupations.
Mm.
Um, there's far more to it, but it's going in with our professional curiosity, which kind of comes from our training, kind of our philosophy, to kind of towards people. So I've completely forgotten what the original question is, but
It was
um,
about occupations and identity when people are going
yeah, yeah,
through recovery.
yeah. Yeah, yeah, I think I covered that one.
Yeah, you have.